Hi, everyone. Okay, good afternoon, everyone. Welcome to the global session of the meeting. I hope everyone had a chance to have lunch and socialize with colleagues and attend one of the great sessions, either the Mercy Shift session or the SOAPS Town Hall or the professional coaching or what have you. I'm Sasha Williams. I am a Global Pediatric Surgery Fellow at Montreal Children's Hospital at McGill. My esteemed co-moderator is Jason Fisher, and he is the Associate Chief of Pediatric Surgery and Professor of Surgery at Cincinnati Children's. Quick reminder to those who are scoring abstracts, please either scan the QR code on the back of your badge or click the link in the email that you had. They're due today at 5:30. So we have a great session planned with some compelling topics. And I'm sure you're all going to enjoy them greatly. So let's get underway. Our first presentation is entitled The Risk Prediction Model for Pediatric Surgical Outcomes in Resource-Constrained Settings. And that will be given by Katie LaRusso at MedStar Georgetown University Hospital.
Okay, no disclosures. So the applicability of quality improvement programs such as NSQIP, for instance, in low and middle income countries is really unknown. The idea of creating a quote-unquote NSQIP light or reduced NSQIP data set for resource-constrained settings to risk adjust surgical outcomes came initially from work in Mozambique with Dr. Stephen Bickler. Often, hospitals in low resource settings keep logbooks that capture important clinical variables, but this data is often used in a systematic way to monitor and improve outcomes or to compare outcomes across patients, across hospitals, or across countries. So our goal was to develop a predictive model for pediatric surgery. We therefore sought to develop a robust predictive model for resource-constrained settings that was based on a limited number of variables that could assist providers in reviewing risk-adjusted data for QI initiatives and benchmarking outcomes across sites. We used NSQIP pediatrics data from 2012 to 2017. We ended up excluding neonates, feeling that they were a unique population that we hypothesized to have different set of risk factors for death. We also included all CPT codes for including general pediatric surgery, ENT, ortho, urology, plastics, neuro, thoracics, and gyne for overall generalizability in our context that we were working, and this included about 450,000 cases. So we only used, NSQIP is a very large data set. We only wanted to use NSQIP variables that were relevant, again, like I said, to a low resource setting. We then used LASSO, which is called the logistic regression with the least absolute shrinkage and selection operator penalty method to pick the predictor variables from NSQIP, because we felt that this model, prediction model, had the highest discriminatory ability for inpatient mortality to really pick the right set of variables. It often helps to reduce overfitting that you sometimes see with some models, for instance, that suggest sometimes in real life a stronger association between variables that really truly exist. LASSO chooses the best subset of variables for a model and ultimately aims to make the results more generalizable to the new data. So from the 133 or so distinct variables, preoperative variables within NSQIP, we excluded those only relevant, like I said again, to low resource settings, such as something like ventilator dependence or tracheostomy. And we used our external validation site as a metric. This data set was reduced to these 21 variables that we felt were relevant, again, feasible, and could be collected reliably in our local context and in many contexts. There were a total of about 45,000 cases. We then divided the cases into 2/3 into a training cohort and another third into a validation cohort. We also, I just want to make a note, we did use complete case analysis was performed to account for any missing data. The final model selected by LASSO is listed here. You can see the variables include inpatient versus outpatient. Oxygen, was the patient on oxygen support or nutritional support at the time of surgery? Did the patient require a blood transfusion within 48 hours? Did the patient get transferred either from home or from an outside hospital? And whether the patient had a life-threatening ASA classification. On the right, you can also see that our area under the curve for inpatient death for this model with these 6 variables was 0.95. It showed a very good discriminative ability for inpatient death. So some of the limitations of our study include that, some of these variables or risk factors for mortality in our local setting may not be captured within this NSQIP data set. We did collaborate with our local team to select variables that we thought were relevant, and we plan to externally validate that data. And our next step, we have about 1,000 surgical cases now in Uganda that's collected that we're going to do external validation with our model. So in conclusion, our model predicted surgical mortality with an excellent accuracy with an area under the curve of 0.95. By assessing pre-surgical risk reliably using such prognostic models, we hope that we can aid in clinical decision-making and quality improvement projects and really help to prevent, validate, or rescue in pediatric patients in low-resource settings. I just want to acknowledge the Jean-Martin Leberge Global Pediatric Surgery Fellowship, for which this research was conducted under, and my current and past supervisors, the team in Uganda who is currently working on the next steps to help validate this model, and I'm happy to answer any questions.
Thank you, Dr. LaRusso. Any questions from the floor?
I also have a follow-up presentation, so go ahead. But it's just FYI, everybody.
Thank you. Sharda Jaharipar from Vancouver. Really interesting. I'm working on a similar thing for adult and peds populations for both morbidity and mortality. I'm really interested that age didn't come out in your variables. Can you talk about why you think that didn't happen?
Yeah.
Just being in settings where often lower age is associated with higher mortality because of discomfort of any status, really.
I think great question. I think in our model, we excluded neonates from the get-go. We already said that they were going to have different types of risk factors for death. So I think by excluding neonates, we really ended up with a different set of variables than if they had been in the data set. That's like one of my theories about it. I also think that the age distribution within NSQIP is like an average, I think, of like 7 or so or something like that. So in the general population, I think the overall, there's just so many cases that it just didn't end up being like a real predictor. On the univariate, it was, I should say. On the univariate chi-squared, it was. But again, with the lasso, it didn't come to be significant.
I'm Monica Langer, Boston, and I really applaud your work, and I think that it's great to develop something that we can actually do quality assessment. That's very important. I'm fascinated for how NSQIP, which is in a very particular setting, will translate. So I think that it'll be really interesting to see how it's validated. When you said you were having other factors that you think are going to be important, how have you determined what those will be? And are you already, is that data collected?
Yes.
Or you're just figuring out as you go?
Yeah, great. Yeah. So we worked with the people the staff in Uganda to sort of come up with other variables that they think are relevant. So we're looking at like time to hospital, as well as like any delay that would occur before the operating room, and to see. So we have about 1,000 data points, 1,000 patients right now collected in Uganda. And within that will be data will include there. They also get some lab work before they do cases. So we also have collected CBCs and hemoglobins on our patients as well. So I think we'll see if this model, some of these variables do matter or not. And then hopefully we'll be able to then even use our 1,000 patients to even develop maybe another risk stratification, like using either logistic regression or lasso. Lasso is really good with large data sets, but we could also just use logistic regression to decide if like there's another model within our data that maybe we can train and validate as well within a larger data set.
Thank you, Dan Panaro McGill. Thanks, Katie.
Yeah.
That was amazing. Beautiful, elegant study. I'm so glad to hear you're going to try to validate with the data that you've collected, 1,000 patients or whatever in Uganda. I guess I'm just trying to understand why would you even consider training a sparse model on US data when your intent is 100% to use it where that data is not available, Why not simply start? Because the problem is you've got 5, 6 variables, but you already are telling us that probably other ones will come out when you look at your data. So I think you don't want to actually run your current model. It's a great invention on its own. It's a great thing you've done, sparse data collection for US, but I think you want to start with your local data, create your own model on the local data based on what they actually have. And that way, it will never, on that model, you're never going to get fancy data out because they don't collect that data, but you actually get what the patients are. Maybe something like transfer, like I was looking at those things. Nutritional status is just like two worlds apart, right? I think it's going to affect in different ways.
Yeah, we'll have to, yeah, great point. We definitely talked about that a lot when we designed the study design and everything. One of the things is that NSQIP does provide an opportunity for high volume of data, right? I have almost 500,000 cases using NSQIP to devise a model for inpatient mortality. And some things like blood transfusion within 48 hours will translate. And so it will be, well, it could, Dr. Langer shaking her head, but our patients in Uganda do get labs, and oftentimes they can receive a blood transfusion. But I do think that some of the data will actually translate. I think that it's important when you develop these risk stratification models, you're using a large data set. And I think even having done this, the data that we're collecting in Uganda now has become much more significant than it would have been before. Like, we would have been a little more like, what variables should we collect overall, and maybe it would have been more vague initially from the start. And this gave us like a little bit more of a target for data that we could collect. That seems to be well tested here with this model that we designed.
Wonderful. Thank you very much. We're going to move on to the next presentation.
All right, we're lucky enough that Katie gets to stay up here.
Yeah, great.
You come up after her second talk, which is entitled Surgical Risk Prediction Model and Risk Calculator for Neonates in Low Resource Settings.
Yeah. Okay, so this is sort of the follow-up study to our last study that I talked about, where we really sought to look at now as neonates at a separate category. And then again, we were still looking at inpatient mortality. And to further, we wanted to continue our kind of work and actually create like a risk score to help make prediction quickly and efficiently. So this is the example of, people have used this NSQIP P calculator. So here, their calculator uses 18 preoperative variables to predict, not only inpatient death, but also postoperative morbidity. So again, we use the same data set from 2012 to 2017, and we looked only at neonates this time. And again, we included all surgical cases, and this led us to have about 17,000, 18,000 cases. So then again, we did the same thing. We did 2/3 into a training cohort. We split 2/3 into a training cohort and another third into a validation cohort. And again, we did a complete case analysis to account for missing data. And then here's our neonatal model. So our neonatal model did include prematurity, so then age became more important, and prematurity obviously is very important. Whether the baby was on oxygen support, blood transfusion, again, was significant. Either whether or not it was an urgent or emergent case, whether the patient was septic and met SIRS criteria or septic shock within 48 hours of the surgery. And then if the patient, again, required either had a life-threatening ASA classification or not. These ones that I've starred here, did all three come up? Yeah, there you go. These ones you can see came in both models. So they do seem to be important in overall predicting inpatient death within at least the NSQIP data set. So the next step was we devised a user-friendly point-based score to classify neonates into low, intermediate, and high risk for postoperative mortality. And you can see the point system there, and it was out of a total of 31 points. So we now plan to validate this model with our risk to validate the model and the risk score with our local collaborators in Uganda. And this will be a smaller data set, which we realize is a little bit of a limitation. However, we do hope our model will continue to capture key predictors of death in the field. So our model predicts neonatal mortality with excellent accuracy with an AUC of 0.91. And both models only utilized about 6 variables, with needing blood transfusion, O2 support, and ASA classification being particularly important. We devised a risk score also with a limited number of variables for perioperative mortality to really easily identify high-risk neonates. And we really hope this may aid in clinical decision-making, quality improvement, and prevention failure to rescue in our patients. So again, there are my acknowledgements, and I'm happy to take any questions.
Ben Warman, Columbus, Ohio. Catherine, thanks for taking on this, rather difficult area. Very strong AUCs for both studies. Congratulations on that. I don't want to belabor the comments that Dr. Panaro had already made. I think I have the same concern that you have. Patients at two ends of the resource spectrum, and you're using NISQIP data, and I think we're all eager to see how you validate.
Yes.
My question is about some of your highest risk predictors, because you're now trying to use this for real-time clinical decision support in some
Yes.
ways, and some of your high-risk predictors, particularly like the sepsis within 48 hours. Sometimes you are not able to completely derive that until actually after the operation is underway. So if you're going to use that for real-time decision support, but it's not, it's a pre-op, variable, but you may not be able to actually completely calculate it,
Yeah.
Until induction or maybe even until post-op.
Yes.
How are you actually going to use that as a decision support tool?
Yeah, thank you very much. Excellent question. I've thought about this a lot. It's very hard to it's very hard to decide that I wanted to go into this work in a quality improvement like methodology, and to really think about how can we actually prevent failure to rescue, and how can you give clinicians on the ground the decision making, like tell them that these patients are going to be really high risk for death, and then therefore they can then make a decision to say, oh, I'm going to do this to prevent that from happening. So that's a great point. I think that it's going to be interesting to see how it works, right? It's going to be interesting to see if it really actually holds up with the low resource data, and whether or not within the low resource data there's other variables that are really more important that could be more actionable. And within this whole project, maybe there's other quality improvement initiatives or another final model that will come about based on all of that. But that's a great point. And it's something that unfortunately having preoperative variables these were what came out of the model, they're not always that actionable and things that people can always change. But I think some recognition that even a kid who maybe had a blood transfusion and sepsis and was transferred from an outside facility or something like that really just should be really monitored very closely.
Hi, Katie.
Hi.
Great talk. So I think this is a really interesting discussion, and I did similar work in the trauma realm. So what you've presented today, I really think in your process as almost a proof of concept. We know it's been described and published time and time again that there's a problem with getting high quality, usable data in resource-constrained environments. And I think every effort to reduce the burden of data collection to valuable, feasible metrics is worthwhile. But I think in the process, as you've said, there's a second step, which is where you have to compare this. We know that this is just, we're calling it a low resource model, but it hasn't been proven yet
Correct.
on the ground. And there's an important second step of recalibrating that model, not only with these NISQIP-derived variables, but with the other ones that you will find thanks to your collaborators on the field. And so we're all looking forward to that next step because I think
Yeah.
it's really important work. Congratulations.
Thank you, Etienne.
Unfortunately, due to time, we're going to move on. So,
Okay.
she'll be available afterwards.
Thank you. Our next presenter is Nema Kaseje from SSRG, Lodwar County Referral Hospital in Kenya. Her work is entitled Unlocking Local Financing for Pediatric Surgical Care in a Refugee and Rural Context in Turkana, Kenya.
Thank you. Good afternoon, and thank you for the opportunity to present our work from Kakuma Refugee Camp. Our pilot intervention was funded by the Rockefeller Foundation. As we all know, we've seen massive recent declines in global health funding, and not just in the US, but across the world. The UK reduced its funding by $1 billion, France close to $2 billion, Germany the same, the Netherlands by $8 billion. And most recently, USAID AID funding has also sharply decreased. And looking at the top 10 countries receiving USAID funding for health interventions, Kenya is among the top 10 and received $377 million in 2023. And this was funding for maternal and child health, also funding for refugee health interventions. So the recent cuts have had a massive impact on healthcare delivery, including surgical care delivery. Kenya hosts about 550,000 refugees. 234,000 are located in Dadaab refugee camp. Another 230,000 are located in Kakuma refugee camp, bordering South Sudan, Uganda, and Ethiopia. Our intervention, located in Kakuma refugee camp, we conducted this intervention in the past 1 year. Kakuma was established in 1992. In addition to hosting the 230,000 refugees, they're also the local community, the Turkana, pastoralist community. Poverty is very high. 70% of the population lives on less than $2 per day. In Kenya, we've had the National Health Insurance Fund since the 1960s. This provides comprehensive health insurance coverage for households. And there was a recent policy change which led to the inclusion of refugees in the National Health Insurance Fund. And so we had two objectives. Number one, to evaluate the feasibility of unlocking NHI funding, NHI financing for pediatric surgical care provision in the refugee setting. And we also wanted to calculate the return on investment of providing health insurance coverage for children in surgical services in our setting. In terms of methods, we registered all children, so both refugee children and Turkana children, to NHIF. We optimized these children before surgical care. There was a recent drought, and so malnutrition went up. So we had to make sure that the children are optimized before surgery. And we also submitted pre-authorization forms, which allowed us to bill for services so that we could move away from the charity model of providing surgical services. We then conducted surgical procedures. This was done by a team composed of a pediatric surgeon, a general surgeon, and a clinical officer anesthetist. We then calculated frequencies of surgical conditions, the average health insurance reimbursement amount, and also the return on investment of every dollar we spent on health insurance coverage, and our postoperative complication rate. In terms of results, we registered a total of 300 children aged 4 days old to 13 years old. Most common diagnoses were hernias and hydrocele. In the neonatal period, the most common diagnoses were anorectal malformations. We conducted 30 procedures, submitted 30 invoices, received 6 reimbursements, and the average reimbursement amount was $1,036, which gave us a return on investment of $22 for every dollar we spent on health insurance coverage. And our postoperative complication rate was 3%. This was due to a premature removal of a urinary catheter following a PSOP, and this required a cystoscopy and replacement of the catheter. The baby did well thereafter. This is a picture of the baby right before discharge. And so in conclusion, it is feasible to unlock local health financing for pediatric surgical care in a refugee setting. The return on investment is significant. For every dollar spent, we unlocked $22. This approach could be a sustainable mechanism for financing pediatric surgical interventions in refugee settings. Complications were rare and were linked to a need for optimizing postoperative nursing care, and we're working hard on improving that. In terms of next steps, we will be advocating for this intervention in global health platforms, including the World Health Assembly in a couple weeks and the World Health Summit in October and Davos thereafter. I'm thankful for the team in Turkana and also our partners, including UNHCR, the Ministry of Health, IRC, and Rockefeller Foundation. Thank you, and I'll take any questions.
Monica, Boston. I think that's amazing work, Naima, and to be really lauded. And I'm fascinated by interventions to improve, to decrease catastrophic financial expenditure. How long between the application and actually getting insured is that? What's the lag period?
So we did run into setbacks. So number one was that we needed birth certificates, which the majority of our patients did not have. 97% of our patients didn't have birth certificates. So that was a huge hurdle that we needed to overcome. And then after that, once they're insured, with NHIF, there's a 6-month waiting period. But with the new social health insurance fund, if you pay for the year, the activation is immediate. So 2 weeks ago, we basically registered all the kids that we were doing, and activation was immediate, and we got pre-authorizations within hours. So this new version of the health insurance fund seems to be more efficient than the previous one, and there are less delays in getting activation.
Thank you.
Thank you.
Ben Wome, Columbus, Ohio. Dr. Kasije, congratulations for this excellent study. Very impressive return on investment, 22 to 1. I hope it did include a consideration for staff salaries and overhead in calculating the ROI, because that is sometimes forgotten when people calculate a return on investment. But my main question is about, your pre-authorization, the coverage kicks in after pre-authorization. Mm-hmm. And I see that the examples that you gave, the hernias, the patients in the NICU, they're pretty much elective conditions. How do you deal with the emergencies since you can't get pre-auth in those cases?
So actually, with the emergencies, with the new version of the health insurance fund, pre-authorizations are processed within hours. There've been some education also among us as surgeons to really have health insurance coverage on our radar. That was, even for me, I had to be more sensitized to that. So in clinic, whether you're seeing the patient in clinic or in the emergency room, that question needs to come up, and we immediately register them. And activation is immediate if you pay for the whole year, which is $60. It's very affordable, and it covers the whole household. And so we've found ways to make it more efficient. And the return on investment is also very high because the demand is so high, and there's underutilization of the fund right now. Just because most people don't know about the health insurance fund, and some who even have coverage do not know how to use it. So even having health insurance does not mean that you will get the services. There's also a need to educate the communities.
Thank you very much. Great job.
Thank you.
Our next talk is entitled Effect of Distance to Care on Pediatric Trauma Outcomes in Central Malawi. It's being presented by Dr. Madushi Zope.
Is this working? Okay. All right. Thank you for the introduction and the honor to present today. We have no financial disclosures, and this project was funded in part by the Fogarty International Center. So a little bit about pediatric trauma in Malawi. For those of you that haven't been familiarized yet from our talk earlier, Malawi is a country in southeastern Africa. It's a little bit longitudinally shaped, so it subdivides into 3 different regions. There's northern, central, and southern. And overall, there's limited access to pediatric surgical services in Malawi. There's no established 911 EMS service, and there's only 2 pediatric surgical referral centers with 7 pediatric surgeons servicing the entire country that are located in the central region, as you can see above, and the southern region. And we operate out of Lilongwe in the central region at Kamuzu Central Hospital. So the gaps in knowledge that we sought to address with this study were, where are pediatric trauma admissions coming from? And how does distance from injury to definitive care affect pre and in-hospital mortality? And to do this, we conducted a retrospective study at our center. All trauma presentations were included, burns were excluded, and then we included all children less than 18 years old from 2018 to 2021 and ended up with 11,161 patients. And then used ArcGIS Pro to calculate the distance from the geographical injury location to Kamuzu Central Hospital, and followed this up with multivariable logistic regression to identify patient characteristics that predicted pre and in-hospital mortality. So overall cohort characteristics, our mean age of presentation was 8.3 years. 70% of our patients coming in were male. The injury usually presented in the hand, chest, upper extremity region at about 40% of our cohort, and the most common injury mechanism was blunt at 68.7%, most of these being pedestrian versus auto. 30.5% of our presenting cohort was penetrating injuries, and keep in mind that in our setting, this is a lot of stab wounds as well as animal bites. And all of this kind of combined together along with an AVPU scoring and a radial pulse presence to create a Malawi trauma score, which has been established by our group over the last couple of years as a locally developed injury severity score for pediatric as well as adult trauma. So the mean was 7.8 in the cohort that we were looking at, and then the distance from injury to care ended up being about 18.4 kilometers. And most of our patients actually survived to discharge at 98.6%, with 1.1 experiencing a pre-hospital death event and 0.3% experiencing an in-hospital death event. So in terms of geographic distribution, where are patients coming from? As you can see, most of them come from Lilongwe District, which is as expected, it was just where we're located. And then when looking at pre-hospital mortality by district, you can see it kind of concentrates in Kasungu District as well as in Kotakota District at about 2.1, 2.4% pre-hospital mortality rates as seen once they are en route to our center. And when looking at multivariable regression to kind of figure out which of these factors is the most predictive, you can see that penetrating trauma mechanism as well as other mechanisms, which include drownings, hangings, poisonings, confer increased odds of pre-hospital mortality, as well as head, face, and spine injuries. And interestingly, in this model, distance to care is not a significant predictor. When looking at in-hospital mortality by district, again, Kasungu alone is one of the spots that gives us 5.8 mortality per 100 trauma admissions that we're seeing at KCH from that location. And again, with multivariable logistic regression, you see now we can do a Malawi trauma score for these patients, and the significant predictors end up being another injury mechanism, such as drownings or hangings, and the Malawi trauma score as established by prior data. And here, distance to care becomes significant. So each additional 50 kilometers from the injury to Kamuzu Central Hospital confers a 2.3 increased odds of in-hospital mortality. So overall, to recap, Kamuzu Central serves as the pediatric surgical trauma center for the central region of Malawi, as well as some of the neighboring districts in the northern and southern regions. For pre-hospital mortality, it's concentrated in Kasungu and in Kotakota, and the predictive factors aside include penetrating trauma, other injury mechanisms, and head, face, spine injuries. And then for in-hospital mortality, it's concentrated in Kasungu alone, and predictive factors include other mechanisms, the Malawi trauma score, as well as distance to injury in this model, or distance from injury to Kamuzu Central. So future directions include identifying limitations in pre-hospital care and transport, with a special focus on Kasungu going forward. And with that, I will open it up to the group for questions.
Thanks very much. That was a beautiful study. And it's exactly the sort of study that we need in order to find out what are the factors, what affects our patients, how can we improve outcomes because of this. I guess the only thing that I sort of missed in here was at the very end, the last slide, in the discussion. So here are your findings. They're very specific. So what? In other words, what are you going to do now before you get to further studies? What are you going to do with your team there to say, okay, based on what we found out, this is what we got to do now, not studies, but like care.
Just talking with the team first.
Well, yeah, and
yeah.
talking to the team about what?
Yeah. So some of the ideas I can say that have been floated around is kind of figuring out exactly what is happening in the Kasungu district hospitals as well as the primary hospitals. We can't really have like a injury severity comparison for the pre-hospital versus in-hospital deaths just because that Malawi trauma score doesn't kick in until a physician at KCH has evaluated them. So one of the ideas that would kind of help suss out exactly what's happening in the landscape would be to try and employ that MTS scoring in a pre-hospital transport setting because, hold on, I'll show my appendix slide. As you can see, the scoring is something that you can do kind of in the field. You don't have to have a full like medical background to do it. So if we're able to start collecting that data, it might help clue us into like what exactly is causing that difference between pre-hospital and in-hospital deaths, specifically from Kasungu district. Okay. Dr. Narowi?
Congratulations. 11,000 children is just such an impressive number. My question is on methodology. So when you are looking at distance, I suppose you are referring to like a straight line distance from the districts to the center, right? I mean, that is always fraught when you're doing these geographic studies, calculating distance. Particularly in Africa where, straight line distance can be so different than
Yeah.
real-time difference, distance. Particularly when you take into consideration rains and road closures and detours. Have you considered using actual time, time to travel to look at your data again? Thank you.
Thank you for the question. The short answer is yes, we have considered it. It's actually difficult to properly evaluate time because we don't have in-transport data per se, so a lot of it is anecdotal reporting from what the parent or the patient guardian notes when they come to us, like how far have you been traveling, how long have you been traveling. That being said, there was actually a study out of northern Malawi looking at adult trauma that kind of did that comparison between time to the hospital with like actual transport time, as well as the crow flies distance, and then distance from the roads like traveled by car. And their sample size was pretty small, but they didn't find like a significant difference in like how each metric reported access or time from seeking access to care and then actually accessing care. So I don't think it would make that big of a difference to try and see like time versus like road travel time just based on that one study alone. But of course, we'll continue to try to get better data as we go along.
Wonderful. Thank you very much.
Thank you.
Okay, our next presentation is entitled Utility of Pediatric Day Case Surgery in a Rural Setup in Sub-Saharan Africa by Bethlehem Waisiko at Bethany Kids Kajabi Hospital in Kenya.
Good afternoon. Thank you for the opportunity to present our work. So, pediatric day case surgery is well established in the West with provision of guidelines by various oversight bodies, as well as the establishment of specialized units in which to conduct these studies. A lack of these resources, as well as various patient and health system factors in sub-Saharan Africa, limit its practice. However, looking at the benefits that day case surgery provides, day case surgery is a potential solution to cater for the surgical needs within our region for the right patient population. Therefore, we did this study in order to share our initial experience in implementing day case surgery, tailoring it to our existent imperfect structures, and using this data to look at areas in which we can improve day case delivery and potentially upscale its uptake within our region. So for context, Bethany Kids is located in central Kenya, And in our institution, we began the rollout of daycare surgery in May of 2021. As a department, we sat down and came up with select procedures that would be suitable for daycare's practice, and then came up with a protocol on how these patients will be attended to in tandem with those cases that require inpatient services, and then looked at this data retrospectively in order to assess what outcomes we have had. So we did this in a two-arm approach, looking at daycare surgery before looking at the outcomes of daycare surgery 1 year after its implementation, comparing with the results that we'd had for these same select procedures 1 year before the installation of daycare surgery. And we tailored our study in order to be able to realize a 3% conversion rate, which has been globally seen as a reasonable measure of the quality of daycare surgery by any center. We ended up analyzing 506 patient files from electronic medical system, and this represented about 30% of our elective caseload. The median age at the time of surgery for the patients that we analyzed was 4 years, and the most common surgeries being done being orchidopexies and hypospadia surgeries. Looking at the type of anesthesia that these patients were exposed to, majority of them were exposed to general anesthesia, with additional regional anesthesia being given in less than 20% of our patients. For our main determinant on the quality of care of daycare surgeries, we had a conversion rate of 9%, which is 3 times higher what is recommended by global standards. With that, we went on ahead to look at the specific reasons for this high conversion rate. I noted that majority of them, up to 60%, were due to social reasons. The main ones being cited were the parents being uncomfortable with going home and taking care of their child, as well as distance and ability to make it home safely, considering the time that the surgery was completed. Conversion rate due to medical reasons only accounted for about 30%. Looking at the median cost of the surgeries that we had, we did note a significant reduction in the cost of our surgeries, accounting for a 17% reduction, with the numbers quoted in terms of US dollars, and we did not note any difference in 30-day complication rate between the two study periods. We were limited in the kind of information that we could retrieve, given that this was a retrospective study. But from what we were able to analyze, we can conclude that daycare surgery is safe and feasible option in provision of pediatric surgical cases in the appropriate patient population. However, social challenges do pose a hurdle to be addressed in order to improve the efficiency of delivery. And since we've done this study, we've had a number of changes within our locality that have improved the access to out-of-hospital accommodation arrangements for our patients. And we look forward to be able to analyze the impact of having these structures around us and how it has impacted patient satisfaction with the daycare surgeries that we do at our facility. In conclusion, I'd also want to thank Professor Mill and the pediatric surgery team at Montreal Children's Hospital for being my hosts at this time. Thank you very much.
So Robin Petrozzi, University of Michigan. Bethlehem, this is great and incredibly impactful if that can be rolled out in other places. Can you speak to some of the logistics that are not just the social factors in terms of where patients and families stay when they come into, to your facility, what the monitoring, but what the discussions with anesthesia regarding, safety, whether it's a hemoglobin level or some of those contingencies, because those logistics, I think, are what make it challenging in many settings where it's just accepted that patients come the day before and are kept overnight for those things that don't always make sense. And then how do you account for patients that don't show up or things like that as you kind of think of future models?
Okay, so to the first question, with the model that we came up with, these patients are fully analyzed in the preoperative period at the time that we decide that they need surgery. So if they need any lab works, that is done purely preoperatively. Anesthesia review is done before we give them the date to come for surgery, such that once they are booked, they are already given a date as well as fasting instructions for the day of surgery, and they can show up and be ready for surgery. So the wait, again, given the various models that we have for financing of healthcare, if the patient is coming in depending on the national insurance, that can range anything from 2 weeks, sometimes to a month. If the patient is a cash payer, again, that depends on their ability to raise the finances that are required for that particular surgery. So it is variable.
Thank you for the wonderful job. My question is a specific question regarding to the commonest case that you have done in daycare surgery was orchidopexy and hypospedia. How is it feasible for hypospedia patients? Which specific hypospedia cases are candidate for daycare surgery? Because proximal hypospedia cases will be very difficult to manage postoperatively with catheterization and so on. So, thank you.
Okay. Thank you for your question. We did not go into the details of that. This is a separate study that has been conducted in our facility, and we did roll out a standardized protocol, particularly focusing on hypospadias patients. And we have been able to manage both distal and proximal hypospadias patients as an outpatient basis. The older the patient is, we have noted that we have a higher complication rate for them, and so they may be electively admitted postoperatively, but the majority of them are able to be sent home on the same day, and we have seen a 50% reduction in our complication rate just using that model. And this was actually presented here last year in this conference.
Wonderful. Thank you very much.
Our next presentation is entitled Capacity Strengthening Interventions to Improve Access to Pediatric Surgery in Low-Middle Income Countries, a Systematic Review, being presented by Manor Malik.
Good afternoon. My name is Manor, and I'm a medical student from the University of Toronto, and I'm very grateful to be presenting our project today. Sorry. We have no conflicts of interest to disclose. So firstly, going over the background for this project. Why I particularly wanted to be involved in this project is that it helps advocate from a shift from short-term solutions that are often externally imposed in global health projects to more sustainable, locally driven improvements. This is a project that's important to explore because there are numerous accessibility barriers to pediatric surgery in low middle income countries. This includes a lack of trained pediatric surgeons and long travel distances and high financial costs for families. We hope to provide a roadmap that individuals planning these interventions can take in order to implement sustainable and ethical solutions. So this is a figure from the Global Surgery 2030 publication. And although not specific to pediatric surgery, it shows that there's, in low middle income countries, a substantial amount of the population lacks access to safe, affordable surgery. We conducted a systematic review and searched the electronic databases for interventions that addressed at least one of 6 Lancet Commission on Global Surgery indicators and that were implemented in a low-middle income country defined by the World Bank. On the flow diagram on the right, you'll see that at the title and abstract stage, we had 9,500 studies. At the full text stage, we had 242, and finally 80 met eligibility criteria. Of the 80 studies that were included, they implemented interventions in 70 low-middle income countries. The interventions targeted 15 surgical specialties, and of the studies that provided data, over 103,000 children were supported. Now, the 80 studies identified 19 different methods of capacity strengthening, but I'll discuss 4 of the most common ones. Firstly, international partnerships. These were long-term bi-directional relationships between an organization in a high-income country and one in a low-middle income, and they targeted a variety of areas of improvement. This could be regulations, policies, training, infrastructure enhancement, and many other items. Secondly, many of the interventions targeted training, and it wasn't just training of surgical staff, but also non-surgical staff, such as nurses, anesthesiologists, and many others. And this recognized that surgery is a team exercise. The training also was focused on local epidemiology. Thirdly, mobile clinics. These were temporary operating rooms or surgical clinics implemented in remote and rural regions, and they also trained the local staff in these regions. And this is important, as in low middle income countries, up to 65% of the population resides in rural regions. And finally, infrastructure enhancements. This included either developing new pediatric hospitals, wards, operating rooms, quality improvements projects, as well as dedicated lodging sites for low-income families. Now, while it's important to recognize the successful interventions, it's also important to understand the barriers that might be faced when implementing such projects. Firstly, the visiting teams often encountered limited resources, infrastructure, and staff, and so it was a priority to train all surgical staff and non-surgical staff and look at equipment donations and infrastructure enhancements. There's also communication barriers between the two teams, and it was vital to include a translator or team member proficient in the local language. And finally, as the visiting team could not permanently reside in these other countries, to address the short nature of visits, virtual communication was used for patient follow-up, monitoring, continuous education, and mentorship between each of the return visits. And virtual education curriculums were also established for continuous education. Our review does have some limitations. Firstly, the included studies use heterogeneous methodology or lacked quantitative data, and a meta-analysis was not performed. The included studies were mostly case series or small observational studies. A gray literature search was not performed, and the search strategy did not include anesthesia-specific interventions. Some key takeaways from this project are that capacity strengthening must establish sustainable solutions through long-term relationships and by tailoring to the local epidemiology. Intervention should prioritize training of the whole healthcare team and infrastructure and equipment support. And finally, there is still an evidence gap. Studies lacked long-term follow-up, quantitative outcomes, and involvement of the low-middle income country team in reporting of outcomes and publication. Thank you for listening to my presentation. I'd like to thank each of my co-authors and their institutions for support in completing this project. I'm happy to answer any questions.
So I wanted to congratulate you for such an outstanding presentation. As a medical student, you had such poise and clarity, and I enjoyed it very much. I actually don't have any question. I just wanted to congratulate you.
Thank you.
Thank you, Ben.
You go ahead.
So, you have a question. I have a question, but go ahead.
No, all the good stuff before repeated that's all beautiful. Just trying to, again, get to the bottom line here. You mentioned at the beginning that the reason you did this systematic review was so that you can focus on capacity, so that collaborations can focus on capacity building for healthcare systems. And at the end of your systematic review, you found out that there isn't any, that the evidence is very limited for those things. And the couple of conclusions you had were pretty straightforward. Like, yeah, it's good to have collaboration, and it's good to have teams and not individuals and stuff like that. So where does that leave you, and how are you able to continue to push for indeed capacity building in the absence of real data that says that it should be done?
Yeah, that's a great question. And I think that is a limitation of the review, that there wasn't that much quantitative data available. And so one of the outcomes that we present is that there should be further research that looks at long-term quantitative outcomes. We also recognize that since the gray literature search wasn't conducted, a lot of the studies and data from low middle income countries isn't published in peer-reviewed journals, and we do have still that area to explore, as well as policy papers. So yeah, that is a limitation of this review, but there is still future directions we can go through to get more information.
All right, great. Thank you very much.
Okay, our next presentation is entitled Comparison of PSI, RPSI, and SIPA in triaging injured children within a resource-scarce LMIC setting by Mark Slidell from Johns Hopkins.
So I am presenting on behalf of my students and residents who are not here for travel reasons. They're just worried about crossing the border. So I apologize. And I will hope to do the best I can for them. They did a wonderful job preparing this talk and doing all of the research as well. So we have no disclosures. Just to give you a bit of an introduction, trauma scoring systems are useful either pre-hospital or on early arrival or retrospectively. And so examples of those that we would use in pediatric trauma are the pediatric trauma score created by Dr. Tipas a long, long time ago, the first score created specifically for children. SIPA, the shock index, pediatric adjusted, which has really pushed forward significantly in trauma as far as thinking about kids differently. More recently, the pediatric shock index. There's another one not on here, Presto. And then a late phase, there's the injury severity score, the trauma composite score, and there's an abbreviated trauma composite score. But you can't use those late phase ones in the early phase. So most of these get validated in a North American setting, and then really what we were interested in doing is validating these in a low middle income country. So we collaborated with hospital in South Africa to look at these trauma scoring systems and try and establish evidence that this specific one, pediatric shock index, could be used to triage children and make decisions about getting them to the appropriate level of care. So a little background for people, the shock index, if you don't know, is simply heart rate over systolic blood pressure. In adults, starting in 1967, this was well established that over 0.9 is associated with adverse outcomes. Children, you need to adjust for vital sign variability by age. It makes sense to all of us in the room, but people really neglected that for a long time out there in the world of trauma. So SIPA was a push forward in 2016, and as you can see, the vital signs are different by age, but unfortunately SIPA didn't really use the vital signs from PALS or ATLS at the time, but still it was a useful tool pushing things forward, predicts the need for transfusion, ICU admission, length of stay, triage, and it also has been validated in low middle income country settings. We did a study a couple years ago looking at ATLS or PALS versus SIPA and found that either ATLS or PALS-based triage systems could be used to more accurately assess for the risk of mortality, PICU need, ventilator days, and ISS greater than 25. Again, we developed this pediatric shock index and compared that to SIPA for the same things and found early transfusion mortality, need for a PICU bed or injury severity score greater than 25 could be also performed easily with these age-adjusted vital signs. So what we did is our students actually went to South Africa, to Pietermaritzburg, and this is a hospital that's probably familiar to a number of people in this room. They have a very robust trauma system, a robust trauma data set. Dr. Damien Clark really does an incredible job maintaining this data set and is a very, very willing collaborator. And our hypothesis is that we could use PSI to really evaluate and triage patients in this setting. So this is the data, this is the data poll. The number of patients we had ultimately was about 2,200. And as you can see from the ages, it's a pretty good mix of ages. It's not just a teenager-heavy data set that you might see at a hospital caring for a mixed patient population. And the mixture of blunt and penetrating is pretty standard, I think, for this setting, so it looked like it was a good data set we had here. And we did find, thankfully, that our hypothesis was supported and that PSI outperformed SIPA in the in-hospital mortality, the need for ICU admission, mechanical ventilation, the need for surgery, and blood fusion. The positive predictive values were not statistically significant, but as you can see, there is this trend towards significance that I imagine with a larger data set, you might have similar findings. So in conclusion, we did find that PSI has value as far as the specificity. The sensitivity is not higher, but maybe that's a good thing. You don't want to over triage unnecessarily, and you can use it for assessing patients for blood transfusion, PICU admission, mechanical ventilation, need to go to the OR, and mortality. And the implications for this is really in triaging patients where there are limited pediatric resources and deciding just basically on heart rate and blood pressure whether those patients may need a higher resource of a higher level of care. And I think this needs to be evaluated as in comparison to other systems in other low and middle income countries, hopefully with larger data sets than what we had.
I'll ask Mark, nice job. I feel like your resident might have done better.
Done better.
Yeah. Unlike,
And my student even better than my resident.
yeah. How do you take this and operationalize this at multiple centers? Like, how do you actually go into a new hospital setting and implement this?
Yeah, I mean, I think the interesting question will be if you have, like in the presentation from Malawi, if you have a child injured further away and you have heart rate and blood pressure, you have some inkling of the severity of injury. Now, their injury scoring system is great because it is useful in that pre-hospital environment with a small number of variables. And I think that's really the key. We did try to look at this comparison to Presto, but it further limited the number of patients available to us in the analysis because Presto also uses O2 saturation and AVPU, so neurologic signs. So I think there's value in that it's asking a minimal amount of data to help you in some of those decisions.
Great.
Thank you.
Thank you. Next presentation.
Right. The final presentation for this session is Gaps in Capacity for Children's Surgical Care at District Hospitals in Sub-Saharan Africa, being presented by Tina Sheyi Olajide.
Thank you very much for the opportunity to present the last and hopefully not the least presentation today. It is often said that about 1.7 billion children lack access to safe, quality, affordable surgical care globally. But that figure was derived from 2015 and 2017 data, and I believe it's safe to say that currently those figures would be way much higher than what was quoted at that particular point in time. The next question is how much progress has been made with regards to scaling up access to surgical care for children. There are currently no standardized ways of characterizing the progress that has been made with scaling up surgical care for children. Some of the challenges include the fact that the efforts that have been made towards this particular scaling up of access to surgical care for children are siloed, even within countries, and there's a lack of data and information from which to, on which to base our assumptions. However, periodic evaluations and assessment would help with generating much needed data, provide benchmarks for comparison, and allow for better planning and deployment of resources in an equitable and a more judicious fashion. So this study was part of a work that was done as, under the Africa Surgical Initiative, which was meant to have been carried out across 47 World Health Organization African region countries and to cover 853 district hospitals across Africa. Each country had country research teams, which included principal investigators at the Ministries of Health, a World Health Organization focal person, and district hospital investigators. We utilized a modified WHO hospital assessment tool, which was pre-tested and translated into French and Portuguese. And we collected data at national levels and also at facility levels. Overall, we had about 70% of the countries participating, covering a total population of about 842 million people, of which 35% were children less than 15 years of age. The hospital coverage was about 71%. And what we found was that the pediatric surgeon density across the region was just a mere 0.13 per 100,000 children less than 15 years. Compare this with the recommended 1 per 100,000 pediatrics, 1 per 100,000 children by, less than 15 years. In these hospitals, we had general duty doctors and clinical officers also offering surgical care. The pediatric anesthesiologist density was 0.03 per 100,000 children. And we also had general duty doctors, nurse anesthetists, and clinical officers offering anesthesia across the region. Only about 19% of hospitals always had pediatric surgery providers available, and only about 53% of hospitals also always had anesthesia providers always available. The nurse-patient ratio during the day and night was 1 nurse to more than 10 patients in more than half of the hospitals. Looking at infrastructure and equipment, about 44% of hospitals only had 1 operating room. Only about 34% of hospitals had functioning anesthesia machines always available, and only about 61% of hospitals always had pulse oximetry monitoring during surgeries. About 28% of hospitals had functional X-ray machine all the time, and about 46% had functional ultrasound machines all the time. The surgical volume was 234 per 100,000, and we conveniently assumed a benchmark of 1,750 per 100,000 children, less than 15 years. About 40% of the hospitals could conveniently offer, according to them, colostomy, pediatric laparotomy, and herniotomy. However, safe pediatric anesthesia was always available only in 18% of hospitals, so you can imagine what the outcomes would be like. Only about 26% of hospitals could always provide blood supply within 2 hours of request. In terms of financing, although 70% of the country said they had health insurance for their population, the median population coverage was a mere 7.5%. And in all the countries, every patient that accessed emergency laparotomy and colostomy experienced catastrophic health expenditure in these hospitals. So summarily, there were gaps in all the, under all the domains that were evaluated, demonstrating significant limitations in access to children's surgery. What actions did we take following this study? Because there was country involvement from the initiation of the study and throughout the entire process, there was country ownership, and this implied that we had a room to advocate for countries to develop locally contextualized solutions. However, we're well aware that that would require significant political will. In Nigeria, however, the findings have made robust input into revision of our national surgical plan, and children's surgery is still being heavily focused on within the surgical plan and prioritized. There have also been curriculum developments for district hospitals done by the Federal Ministry of Health, the Postgraduate Medical College, and National Council of Nurses and Midwives. And this curriculum is to retrain surgical care providers in district hospitals to ensure that surgery being provided is safe, and children's surgery is also very well focused on within this curriculum. The findings from these studies have also been a focus of repeated discussions at the Pan-African Surgical Healthcare Forum, which is a forum that brings together policymakers, technocrats, and ministers of health across Africa to develop locally contextualized solutions to advance surgical care within the continent. In conclusion, despite advocacy initiatives and interventions, severe gaps and limitations still exist. However, these are not insurmountable. We continue to advocate for integration of children's surgery into country and regional healthcare plans, and this will help to ensure directed investments towards scale-up of access to children's surgical care. Thank you.
Thanks, Tina, for a beautiful presentation. It's very important to know after the Lancet, 10 years after the Lancet, that things are still not good. I don't think that anybody expected at the Lancet in 2015 that within 10 years things will be all good. Even the WHO goals, UN Development Goals are very much aspirational rather than actually happening. What I'm curious about is, you've shown that things are bad, are still very bad for kids. They were bad in the past as well. Were they badder? Were they more bad before? And I wonder if it wouldn't be very useful to look at countries where these markers were actually improved significantly, and others where they didn't because you went right across the continent, and then identify the actual countries where they didn't work. It didn't get much better, and then try to find out what are the things to do, because we all know that it's advocacy and it's this and it's and SOAPs and so forth, but really for some countries it works, for others it doesn't. What can you talk about that?
Thank you very much for your question. That's very good question. One of the reasons why the results in this study have not been fragmented by country is because one of the what's the word I'll use now? Agreements with the countries was that their data would not be put out individually. So every country has access to his own data, and they decide what they want to do with it. But for us, as the overall scientific committee that carried out the study, we had access to present the whole study together, all of the results as a whole. Now, because I have access to individual data for each of the countries, I can tell you things that are still very bad in all of these countries. I don't think any country is excluded from the badness, so to speak. But the reason why we did this work was not to portray the badness, but to provide benchmarks against which we can further evaluate ourselves in the light of all these interventions we say we are carrying out. Are we actually making impact? Is there any improvement? Do we need to reevaluate our interventions and devise new interventions? Because if we don't have these benchmarks, then we're going to keep patting ourselves and saying we're doing well, but we don't know. So now that we have these benchmarks from 2022 to 2023, then further evaluations can tell us whether the interventions are working or not. And if they're not working, let's do something different. And that's what we're trying to say from this study. I forgot to mention at the beginning that this was not just to portray the badness. Thank you very much.
That concludes our session. We have a break now until 4 o'clock where scientific sessions resume. And in case you take a very long break or an extended break, the president's cocktail reception starts at 6 to 7, and then the presidential banquet to follow. So please enjoy, and hopefully we'll see you there. Thank you.
See you there. Thank you.